Nearly here, use of force specialist, soft restraint kit expert, and welcome to another episode of... They tell you that your only option is to do what feels wrong, to restrain a child, to hold them down, whilst the nasogastric tube is forced past their process. We didn't feel we had a choice. I felt coerced into restraining the patient. It felt wrong. All familiar things that we've seen published in this recent document. It felt wrong because it was wrong, and it's no wonder staff felt coerced. They weren't trained for this. But why not? If it's foreseeable, if it's part of the care required in these settings, then why aren't staff prepared with the least restrictive, least harmful options? One patient's family brought one of our brochures to the care team asking for these tools because they work for the patient, and she didn't want staff putting hands all over her, damaging the relationship, but she knew that she needs some measure in place to help support her through the intervention. And instead, there's a disturbing trend, one highlighted in this latest NHS document, and it's the concern over the use of security staff in clinical settings for managing restraint during medical procedures. Security staff that are SAA registered but only have the base level requirement for physical intervention. Think about the damage that this is going to do to the patient, already terrified and vulnerable, and to the staff asked to step into a role that they're neither trained for nor emotionally prepared to handle. So what then happens when we turn a clinical need into a security issue? This isn't just a question of compassion, it's one of safety and legality. Turning to security guards in these moments risks catastrophic outcomes, not just for the patient, but for those holding them. When things go wrong, who will bear the blame? Who will shoulder the trauma? The law is clear. Using the wrong methods or untrained individuals doesn't just put people at risk, it's unlawful. A few years ago, when the Restraint Reduction Network put out an appendix which directly contradicted care standards and had to be disregarded, is it these fake proposed bans that keep popping up? The knee-jerk reaction to reject safer tools like mechanical restraints and opt for things like prolonged holding, multiple numbers of staff. Where are we getting security? Is it because the clinical staff either aren't trained how to hold people properly or aren't strong enough? But denying effective evidence-based options doesn't solve the problem, it just makes it worse. They lie when they tell you there's no better way. That's it for me, Doug Melia. Until next time on...